Thanks for coming this afternoon. My name is Bethany Muchmore. I'm a bachelor's trained nurse working on my doctorate in psychiatric mental health nursing. We have already filled out our pre-surveys, and today we're going to be talking about an introduction to mental health for children in foster care. So to understand mental health, we have to go back a little bit. First, we're going to talk about DNA. DNA is the material in our cells that carries all the information about us, how our lungs work, how our eyes look, how our hair looks. Each part of our DNA is made up of different sections, and each section has 4 different chemicals that can be the base, and they repeat over and over and over and over and over. There are 3 million bases in our body that make up our DNA, and the order they're in each section determines if you have blonde hair or red hair, blue eyes or green eyes. It's all about these bases. The order in which they are formed and put together makes up our cells, and that's what makes a gerbil, and a person. It's just the order of these bases in our DNA. So your genes can play a very important role in your health, but so does your diet, your activity level, and your environment. Nature versus nurture. This is the nurture part of it, and that's called epigenetics. Epigenetics are the things that affect your DNA that either turn signals on or turn signals off. So you can think of it like a chocolate chip cookie. Your DNA is all the ingredients, the flour, the sugar, the butter, the eggs. The epigenetic is the measuring spoons. That tells us how much of each thing we're going to get. That's your diet, your activity, your environment, your relationships, where you live, the things you're exposed to. Those are the measuring spoons. Those tell us how much of each of our ingredients we're going to get.
That's a great analogy.
Then your body reads the recipe and puts those ingredients together into your cells. And your cells make up your body, which is the whole chocolate chip cookie. So the cells in our brains are called neurons. And when neurons connect with each other, they form a neural connection, neurons connecting. These connections are how we understand the world around us. A baby has 100 billion brain cells at birth, but most of them are not connected. They can connect at a rate of 1 million connections per second from ages 0 to 3. And then even into adulthood, it's about 1,000 to 10,000 per second. We are always connecting things in our brain, but ages 0 to 3 are really critical for good nutrition, interactions, environment. All of those things play into how baby's brain is formed. And these connections become stronger with repetition. The more times we do something, the more our brain gets used to it, and it kind of takes it from one quick connection to a stronger connection and stronger until there's like a big highway in your brain. So when you say, I need to brush my teeth, you know all the steps involved in that because you've done it so many times. Or when a baby practices going to touch the outlet and the mom says, no, 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 and you have to say it about 100 times, you're forming those pathways in the brain so the baby knows, oh, I'm not supposed to touch that one. Baby's brain adjusts, adapts, and fine-tunes itself based on the information received from its environment. So we have 2 illustrations here. This one is an infant attachment cycle. When the baby cries, the grown-up hears, and they come and attend to the baby, and it builds trust. Baby feels safe. There's a connection. Baby knows their needs will be met. There's a connection. Baby can trust adults. There's a connection. And when baby is safe and connected, they can feel free to start exploring and learning more. On the other hand, if baby cries and no one comes, baby does not feel safe. Baby does not build trust. And if baby can't trust to get their needs met, then they can't move on to learning more skills. They're still stuck at getting their basic needs met forever and ever. And if someone steps in, like a foster parent, who can meet those needs later in life, you may have to start back at an infant level in their brain because they're still stuck at my needs are not met. And you may meet their needs, but again, it's going to take lots and lots of repetition to build those safety pathways in the brain so that that child whose brain thinks like a baby can start building, I am safe, my needs will be met, before we can work on any kind of higher level skill. So, trauma and neglect is one of those things that can rewrite the brain, can turn those switches off and on. Trauma can actually change the actual size and shape of the brain too. So when we go back to our ingredients and our measuring spoons might put in this much of this chemical and this much of this chemical in our brain. With enough trauma and neglect, we're gonna dump in the whole bag and it's gonna change the whole shape. It's like if you're making your cookie dough and you put in way too much flour, it's not even gonna come together. Or you flood it with vanilla or water or something, the cookie dough is not even gonna come together. The physical brain cannot come together the way it needs to with enough trauma and neglect. So research indicates that there's something called adverse childhood experiences. This is a study that was done in the 80s, and they defined 10 major adverse childhood events that can happen. The higher the number of your ACEs score, your adverse childhood experiences, the higher the number of your ACEs scores, the more likely you are to experience mental illness. So these include things like physical, sexual, mental abuse, physical and mental neglect, having a parent incarcerated, losing a parent through death or divorce, domestic violence of the mother in the home, having a parent with a history of mental illness or depression. And then, so children in foster care come to foster care with at least a certain number of ACEs. That's why they've been removed. Something has happened in their life that has been traumatic or neglectful. At the very least, they have been removed from their parents and put in foster care. So that is a major adverse childhood experience. So they come to us, typically, studies have shown that children come into foster care with 5 to 6 ACEs on their score already. So children in foster care are 3 to 4 times more likely to experience mental illness than the general population, and about 50% of children in foster care experience some type of mental illness. So about half of all the children you'll get in your home will need some assistance with this. The most common diagnosis for youth in foster care is ADHD, attention deficit hyperactivity disorder, which is not just attention deficit, it's actually a hyper focus on certain things and then your brain forgets other things. Other common diagnoses can be alcohol and substance abuse, anxiety, depression, bipolar, and then there's several levels of oppositional defiant disorder, conduct disorder, intermittent explosive disorder, and then this can lead into things like sociopathy as an adult. There's also developmental delays and learning disabilities that can be the result of trauma, autism, eating disorders, mood disorders, post-traumatic stress disorder is also a common one. There's also an increase in physical ailments. When the body has too much of its stress hormone from the environment, that big old measuring spoon of stress hormone gets dumped in the body. Your body is so busy fighting off the stress that sometimes it can't fight off physical illness as well. So children in foster care tend to be sick more often until their body feels safe. And sometimes beyond. Sometimes it's a lifelong thing. The switch is on and we can try to help calm some of the switches down, but it doesn't always work. It's not an easy, if I change this will go back. Let's see, there's also reactive attachment disorder, which is just that cycle of a child feeling mistrust continually and makes it hard to form relationships. And then suicidal ideations and attempts are increased for children in foster care, as well as inpatient mental health stays because of all the other diagnoses. So some of the common behaviors we see with these diagnoses include executive functioning difficulties. That's like starting a task. If you say, go clean your room, they have no idea where to start. So you might need to change your approach and say, please pick up the clothes on your floor. Be very specific about small things you need them to do, or even brush your teeth can be a very overwhelming task. Well, what do I do first? What order do I do this in? How do I do this? And we know, get out the toothbrush, get the toothpaste, maybe wet your brush, get the fronts, get the sides, get the back. It's a lot of instructions when you think through every step. So that's one thing that can be difficult. Social difficulties. If you haven't been in an environment where you've received good social input, you don't know how to interact socially with others. Academic difficulties, rebuttal of authority. Again, if you don't trust people in authority, you're not going to respond well to people in authority. Rebuttal of affection, antisocial behaviors, that's like theft, lying, self-harm and suicide, sleep problems, and this can be not sleeping enough or sleeping way too much. Sometimes children shut down and sleep for way too long as a way to manage their anxiety and mental health. There can be tics, mood swings or meltdowns, low stress tolerance, risky and impulsive behaviors, complaints again of multiple physical ailments, which may or may not be grounded in actual biology, but it may feel real to that child. We're going to treat every ailment as if it is a real ailment. Eating issues, dissociation, which is not just multiple personalities, it's like checking out. The child is not listening, the child is not here. And hypervigilance, where a child is always on edge. And that's just some of the behaviors. You may see more with your child, but those are some of the common ones. So how do we help? We can help our kids through a team approach. Parent and team involvement, which means biological parent and foster parent or adoptive parent. Team involvement, medication, and therapy. So we're going to talk about each of those elements a little bit and how we can help our kids with their mental health. Teamwork, the impact of parental warmth and empathy, having a prescribing provider, therapists, school, friends, community supports, all of those impacts together can really help a child sort of work through their mental health. Maybe not overcome, but work through. Having enough supports for the child's mental health promotes foster parent retention, reduces placement moves, increases self-efficacy for both the foster parent and the child. If they have enough people in their court, they feel like they can start to kind of take on some more tasks themselves. And it may actually increase behaviors before improving them. There was a recent study done where the researchers assumed that with great parental warmth and a new environment and a loving foster home, that difficult behaviors would decrease, when in fact they actually found the opposite. In the most connected homes, for the first 12 months, behaviors increased. And they hypothesized that was because children felt safe enough to start processing their emotions, and they felt safe enough with those people. They didn't have to just hide it all the time. They could start to kind of work through their emotions. So when a child comes into your home and they may actually act worse for you, it's not necessarily a bad thing, but it is something to get your team working on with you. It also improves their sense of belonging, and it helps everyone be on the same page. As a foster parent, this mostly falls on you to communicate to the entire team, this is what we're doing. And then a prescribing provider may say, we want to start this medication. So you get to say to the social worker and the school and your pediatrician, this is what we're going to start doing. And then the therapist says, here's the technique I want you to try for this. Well, then you go to the CASA or the GAL and the social worker and the school. And so keep good notes in your binder from each provider and communicate well to the team. That's kind of your job. You're the manager of your child's team. So how do we as parents help? We've got a bunch of techniques here. The first thing is knowledge. Understanding breeds empathy, and patience. So learn all you can about your child's diagnosis and about trauma. The more we understand trauma, the more empathetic we are, the calmer we can be for our children. Also, we're going to remember that all behavior is communication. Why is my child behaving this way is really, what is my child telling me? What do they need? What are they trying to communicate in this moment? And then we can provide a safe environment. Predictable routines. We eat breakfast. It doesn't have to be at the same time every day, but we eat breakfast, then we play outside, then we go to the park, then we eat lunch, then we have video time, whatever it is, a predictable routine so your child is not staying up till 2 one day or going who knows where. Not to say they necessarily had an unpredictable life before they came to your house, but that's sometimes the case. So the more predictable you can be, the more those pathways are going to solidify in a good way. Attachment, we're going to build through play. Playing is the work of childhood, said Mr. Rogers. And we are going to connect before we correct. We're going to play with our child and build as strong an attachment as we can. We can also do that with a therapist, a play therapist. And then when our child does a behavior we don't like, we're going to connect with them first before we correct them. We're going to get down at their level. We're going to speak kindly to them, and then we're going to talk through. Once we know they're calm and they know we're on their team, then we can talk through the behavior. Next is reasoning. Children don't just want to be told because I said so. Nobody wants to be told because I said so. Your boss comes and says, do this report you already did, and you're like, why? Because I said so. That's not going to fly. As much as you can, it helps to give children the why. We need to go wash up before dinner. Why? Because there's germs on your hand and it might get on your food. It can be a real simple, quick explanation, but the more you can explain to them, the more in charge they will feel and the more they will trust you. Next is prevention. We're going to work to prevent triggers. First, we have to identify what triggers our child, and then we're going to work as best we can to prevent those. If you've ever been around any toddler, you know that every meltdown is not preventable. It's going to happen, but we're going to prevent what we can as best we can. We're going to empower them with food and water and sleep, and then access to breaks or stimulation as they need it. A great thing for children is to hang upside down on the couch. It helps recenter their brain and body. So when your kid is doing flips on the couch, if you can find a safe place where you can allow them to do that, that's actually great for their brain. And a lot of times children melt down just because they need more water or more food. Think about how long it's been. It's about every 2 to 3 hours at minimum that children need something in their bodies to keep their blood sugar going. The next thing we're going to work on as parents is modeling. We're going to share our calm, not join their chaos. And just like I said, kids form those pathways in their brain through repetition and practice. That's what we have to do. Practice, practice. It's very easy to react at their level when a child escalates to escalate, and you have to be the boss and you have to be in charge and you're going to be above. That actually triggers a lot of our kids. We're going to stay down here. We're going to talk low and slow, and this takes practice. So all the time you're expecting from your child for them to be working on their trauma, working on their mental health, trying to progress, you get to too. We're going to work together to become better people for each other. Validating and narrating. Once the child is calm, we are not going to do this when they're escalated, screaming, throwing things, because they're not going to hear it. When the child is calm, we're going to narrate. You felt really mad, so you were throwing things. You looked like you felt really anxious. Is that the word you would use? And we're going to name their emotions for them, so in the future, instead of throwing something, they can say, hey, I feel this way. Again, this is not going to work the first time, or the second time, or the third time. It's going to take a lot of rewriting. So we're not even going to worry about the outcome for a while. We're not going to worry about what our child does for a while, how they respond to this. We're going to do our part. We're going to follow through. We're going to work on rewriting those pathways. Every time you have an interaction with your child where you follow these techniques, it's one little strip in the highway. And it's going to take a long time to make a new highway. So we're going to be patient with ourselves, and we're going to practice our skills during calm times. We're gonna practice breathing. We're gonna practice giving ourselves nice big hugs. We're gonna practice connecting and playing games together. We're gonna practice losing at games. We're gonna practice hearing the word no by playing silly games about yes/no questions. And we're gonna do this when they're calm so that we can do it eventually when they're dysregulated. You can't practice for the test during the test. You have to practice and study before the hard moments. A play therapist or your child's therapist can give you lots of games to play with your child to help work on whatever their lagging skills are. They could even help you identify what the lagging skills are. So medications. Mental health medications work on various brain chemicals to increase or decrease them to appropriate levels. We're figuring out the measuring spoons with the use of medication. We're gonna get the right amounts of things in there. Medication does not cure mental illness. It helps manage the symptoms so that therapy techniques can be effective over time. All it's doing is lessening symptoms so that therapy can be effective. The hope is that eventually, with enough medication to calm symptoms and enough therapy to put techniques in place, eventually your child may not need as much medication, but it kind of depends on what their diagnosis is. Each person responds to medication differently, so it may take a while, a few different medications to figure out what is right for your child, and then your child's going to grow and change, and their needs may change again. So we're going to do a quick basic overview of some of the medications your child may be on. This is not exhaustive, but there's a few categories of medications. These include antidepressants, things like Prozac and Zoloft. There are anti-anxiety meds like Valium or Xanax, stimulants like Adderall or Ritalin, mood stabilizers, lithium or Depakote, sedatives. Don't knock your child out, just bring them down a notch if they have the right dose, like Ambien, and antipsychotics like Risperdal or Zyprexa. Your doctor should go over your choices with you, why your child is on that medication. The interesting thing about mental health medications is there's a lot of overlap between diagnoses and which medications are used. So it may say, if you look up the medication, this is for autism, and you say, but my child doesn't have autism, they have ADHD. Well, there's a lot of overlap, so you can discuss with your doctor why they've prescribed that specific medication for your child. Lastly, therapy. I'm gonna be honest with you, it can be hard to find a therapist, especially for children on Medicaid in Indiana. There's a lot of types of therapy that we will cover on here. These are wonderful if you can find them. You may have to start with the therapist that is available for your insurance and your child's age and be on a waiting list for a while for your preferred therapy. Obviously, if you feel it's detrimental to your child, you're not going to continue with therapy, but starting therapy with your child and then waiting for the perfect therapy is an okay way to start. So there's child-parent psychotherapy. This is where child and parent work together. Cognitive behavioral therapy, that's what we usually think of when we think of therapy. Sitting down, talking through your problems, someone helping you process through what's happened. Obviously that's going to be a little more beneficial for older children and teens. Acceptance and commitment theory. This is, instead of trying to identify the behaviors and change them over time, we're going to accept them as part of who we are. We're going to make more connections to the people around us and just kind of accept what's happened to us. It's just a different kind of mindset. You and your team can decide what's the right therapy for your child. Dialectical behavioral therapy, it's similar. It's to cognitive behavioral therapy. It's a talk therapy. The emphasis is on education of emotions and social skills. So this might be used more with something like autism. And then there's EMDR, eye movement desensitization and reprocessing. This is a special technique that some therapists are trained in. where they give a stimulus and have you watch something back and forth while you're talking, and it helps reprogram some trauma in the brain. It's actually lots of good research coming out about the effectiveness of that. Then there's parent-child interaction therapy and play therapy, which can go hand in hand, working together, promoting your connection. Play therapy, a child will sit with a therapist or a parent, play through some games and talk about how they felt during the game. A lot of times the child will lead the game, the parent will just follow along and do what they're told. It gives the child control, it helps them narrate their own story. Then there's psychodynamic therapy. This is talk therapy to understand past experiences and how they influence future experiences. Again, good for older children and teens. And then there's some special ones like animal therapy, art therapy, or music therapy that can provide a lot of comfort to a child, a sense of safety. And then there's more concrete therapy like physical therapy, occupational therapy, and speech therapy. If your child is under the age of 3 in Indiana, they can qualify for these therapies through First Steps. You just ask your caseworker for an evaluation. In my experience, they're pretty quick at getting First Steps evaluations going. For older children, past the age of 3, they can access those services through the local school district. Even if your child is not yet enrolled in a preschool or kindergarten program, after the age of 3, the local school district will provide those types of therapies. So they'll do an evaluation of your child, let you know what they recommend, and you can get your services that way covered by the school district. So, to conclude, when we need help with our children's mental health, we're going to start with our caseworker. We're going to tell them what we see, possibly what we think we need. If we have no idea what we need, we're going to be honest about that and say, I don't know what to do with this child. Somebody help me. I've never seen this before. They're going to direct you to find a prescribing provider. It would be great if you had some assistance with that. You may or may not get assistance with that. You can start with your pediatrician. You can also get on the Medicaid provider website, which is on the handout I'll give you, for how to find that information. And you can look up mental health, either psychiatrist or therapist in your area, and it'll give you a list, and it'll, on the Medicaid website, it has the ages they take. And then honestly, you will have to call several around you and see for sure if they are taking patients, what age they're taking, what diagnoses they specialize in. So you'll find a therapist and a prescribing provider through there. Again, you can check with school resources. Once the child is past the age of 3, they might offer physical, occupational, or speech therapy. They might also offer life skills or some kind of play therapy or cognitive behavioral therapy. And then there's wraparound services. Once you have tried other options, you can discuss with your caseworker wraparound services, which is in-home family therapy for children who've struggled to get the care they need elsewhere. If you feel like you're out of luck, you don't know where else to go, you can call your local health department. They can tell you some local resources and the emergency room or 911 if all else fails, to help get the child immediate help for dangerous situations. So that is our presentation. I will have you guys fill out your post survey. We'll see if we've learned anything today. And then I will send you home with your handout that has a brief overview of the information we've covered today, including a giant section at the bottom of those resources that I mentioned. So thank you for coming.